Good evening. I have the honor of welcoming you to this event. I am Carla Sampson, clinical professor and director of 2 of our 3 health programs here at Wagner, the online MHA and our MPA in health policy and management. And, really thinking about this event, which is a brainchild of our alum, Elizabeth Wolff, who I will introduce, navigating H.R.1, the One Big Beautiful Bill Act, which I will from now on call H.R.1, the challenges and opportunities to the healthcare sector. I wrote recently that the evolution of healthcare in the US has always been linked to its financing and shifting fundamentally with key legislative interventions. This is one such intervention. According to a preliminary analysis from the Congressional Budget Office, H.R.1 reduced federal healthcare spending by approximately 1.5 trillion with a T, 1.15 trillion over the next decade, and will also reduce the number of uninsured individuals by 11.8 million by 2034. So this latest piece of legislation really is a monumental shift that we're going to talk about tonight. All of us are really thinking about how do we navigate this new landscape, and so we really have to have this conversation tonight. Our esteemed moderator is Dr. Elizabeth Wolff. Dr. Wolff is a physician executive who utilizes her expertise in population health, quality improvement, and practice operations to transform primary care to align with value-based care. She is currently a principal at Health Management Associates. She's also a member of the advisory board for health programs. She came to that role from Northwell Health, and any Northwell Health people in the room? Biggest employer in New York? Okay, I don't have to say that. Where she served as medical director for complex care management. In that role, she expanded care management to 40 primary care sites undergoing patient-centered medical home transformation, strategically realigned the team to prioritize patients in full risk and other value-based arrangements, and oversaw the integration of behavioral health in 17 primary care practices. Prior to her tenure at Northwell, Dr. Wolff has held numerous leadership positions in public health, federally qualified care centers, and not-for-profit health systems, and oversaw clinical quality and operations. She chaired evidence-based medical committees in both medical groups and ACOs to develop clinical standards and optimize electronic health records. She negotiated quality metrics with health plans and strategically aligned provider quality incentives with payer contracts, with significant improvements in important areas such as diabetes care and colorectal cancer screening. Since joining HMA, this bio is long. Dr. Wolff has assisted primary care practices to implement behavioral health integration, create care teams, develop care management programs, and optimize clinical operations. She has coached primary care practices in their implementation of substance use disorder screening and medication-assisted treatment for opioid use disorders. With such a wonderful expertise, the only thing that I will add is that she received a Master of Public Administration where? Right here, NYU Wagner, and is board certified in family medicine. Please join me in welcoming our moderator, Dr. Elizabeth Wolff.
Thank you, Carla. I don't know if I need a mic because I grew up on a dairy farm, so I actually have a really loud outdoor voice. But I'll use it for now. Thank you very much. It's funny that in my organization, I often give my colleagues a hard time for doing too long of an introduction, so I definitely need to shorten my bio, so apologies for that. I'm going to be introducing our panelists, and I will be much more succinct with their bios, because they've already done that work for me. So immediately to my right is Channon Lucas. Channon is the Chief Administrative Officer and the Executive Vice President of External Engagement at the Mother Cabrini Health Foundation. If folks as you know of Mother Cabrini, okay, so lots of nods. This is a private grant-making foundation that was founded in 2018 and is the largest health-focused philanthropy in New York State and one of the biggest in the country. Since its inception, they have given out about $1 billion to folks. And Channon, as the Chief Administrative Officer of EVP, she's tasked with overseeing day-to-day operations of the foundation, as well as external relationships, communications, and community engagement. To the right, so thank you for this is like whole amazing. So to the right, Debbian Fletcher-Blake. She is the CEO of VIP Community Services in the Bronx. It is an incredible organization that does medical care, behavioral health, housing, and community support. So really unique in the incredible scope of services that they provide. Debbian is a family nurse practitioner with a Master's of Science in Nursing. She's also clinical director at the NYU College of Nursing. And when she has a free moment, she also serves many key roles at the National Health Service Corps, the National Council for Mental Wellbeing. Those of you who know it's called NACON, and also on hospital boards like Montefiore Nyack Hospital. I will say personally, Debbian and I met many years ago. We both worked for a community health center in the city, so it was great to reconnect several years ago. And then last but certainly not least is Errol Pierre. Errol and I overlapped at NYU Wagner by a few years, so he was a graduate in 2013. So another Wagner alum. Errol's career has really been focused in health plans, and he's presently the Chief Growth Officer at Health First. And before that, he was the COO of Empire Blue Cross Blue Shield. And in addition to the Wagner degree, he has a PhD in business administration from Brook. He is also an adjunct professor at Wagner, and serves on the board of the Citizen Budget Commission and the Earth Institute for Health. And I think what's really interesting is he is also a published author, and he's the author of the book, The Way Up, Climbing the Corporate Mountain as a Professional of Color. And thank you all for joining us today. These are interesting times in our country, so glad that we can have this conversation. I think Carla did a wonderful job teeing this up, talking about the incredible expected deficit in healthcare investments over the next decade, over $1 trillion. So I just want to start with a kind of a softball question for the panelists here. So given the massive projected reduction in federal healthcare spending, which is expected to be, and on top of that, it's expected about 12 million people in addition, there'll be an additional 12 million people without healthcare insurance. How are your organizations preparing to manage the ensuing financial strain on Medicaid-dependent safety net providers? So Debbian, as a provider, and then Channon and Errol working closely with providers, how are you helping them manage this eminent financial strain? And maybe Debbian, just as a provider perspective, can we start with you?
Sure, thank you, Elizabeth. I was so sure you were going to start with me. So, as Elizabeth said, with so many people who are predicted to lose their health insurance, it makes it very difficult for organizations like UNLV. And just a little bit about my organization so I can set the stage and you'll understand. We are a federally qualified health center. We're also a certified behavioral health clinic, and that falls under SAMHSA, Substance Abuse and Mental Health Association. We provide housing and shelter and also workforce development and a lot of work in the community development outreach. We were the first or nonprofit organization to be awarded by SAMHSA a harm reduction grant, which is not a bad word. And so, back to your question, Elizabeth, the most important thing for us is preparing our staff for what is coming, because our staff, they have to educate our patients, and also a lot of our staff, their families are also at risk of losing their health care coverage. And then the patients, because, you know, without the patients, we are nothing, right? We can't exist without the people that we take care of. And it's a fundamental shift in the way that they will receive their health services. There's so many people who will be losing their insurance. Currently, people on Medicaid, the redetermination for their Medicaid benefits where they get reauthorized is 12 months. This is shifted to 6 months. And for new enrollees, we had a 30-day look-back period, and now that is shifting to, we had a 3-month look-back, and now it's shifting to 30 days. So that's incredible strain when we're thinking about a workforce, a healthcare workforce that has been challenged since COVID. We haven't really recovered workforce since COVID, and now there is additional work that's been placed on the workforce. So that's one area, and then, you know, we have to think about financial, because we rely in my health center, over 70% of the patients are enrolled in Medicaid benefits. And so when you think about over in one of the congressional districts where we serve, 84,000 people will lose their benefits. And so 60% of our patients are from that congressional district. So that in itself is going to put us in a different financial position. And so now we have to pivot and start thinking about how we shore up our financial resources and what that's going to look like, and how we provide financial literacy to people who will now be losing their health coverage as they come in.
Great, thank you. Debbian.
Errol, what about from your perspective?
Sure. Loud. So I would break it up what we're doing in 3 parts. The first one is education and collaboration. The second one is quality, and I'll explain this in more detail. And the third one is administrative ease for the providers. So Health First, we're the largest nonprofit health plan in New York City. We have 2.1 million members. Half of them have Medicaid benefits. So we are likely trajectory to lose the most members of any health plan just because of our size of who we are in New York City. So I talked about education and collaboration. Debbian is exactly correct. Eligibility will change to every 6 months in 2027. But educating the community in language that's culturally relevant, so that if someone speaks Urdu, someone who speaks Urdu can explain to them what's happened. If someone's in Brooklyn, Crown Heights, and speaks Haitian Creole, you can explain it to them in their language that's culturally relevant. To say the 6-month recertification that's going to happen is specifically to childless adults. And so what tends to happen is everyone gets alarmed, even though they're not all not impacted by the impact. So this is the bill pretty much targets, for the most part, from an eligibility perspective, adults 19 to 64 who do not have kids, that are not working, and those are the ones that are going to get caught up into this 6-month research. So what we have to do is make sure that the community doesn't realize everyone has to. It's going to be difficult because now people are used to recertifying once a year, and then so you have to kind of bifurcate the populations to say, well, let me understand who you are before I tell you if you have to recertify half a year or once a year. Another impact that's happening, which is why I brought up quality as number 2, is acuity. And so if you think about the people who will fall off, the demographic I talked about is these 19 to 64 childless adults. They tend to be lower utilizers, they tend to be healthier. If you're a pregnant mom, if you have SSI, if you have children, you don't have to renew every 6 months. So they're likely to stay on the books longer than the ones that don't. And that's an acuity shift, which means the book that remains enrolled will probably use more services, which exacerbates the financial strain. These are going to be members that need to get their services. So we use quality. Quality basically is HEDIS measures and core measures. These are all measures like making sure women get mammograms, making sure children get immunization. There's a whole list of quality metrics at the federal level that we try to encourage our providers to do. VIP is part of our quality program, and if they hit those metrics, we give them additional funds. And so one of the ways to offset the loss of membership is putting money into our quality program. So as doctors perform and hit these metrics of bringing patients in for checkups and all of their visits, they get extra additional dollars on top of the reimbursement. And that's going to be very important to try to offset some of the disenrollment. So that's the quality piece. And then administrative ease, the last piece is we did a ton of work when redeterminations happened after COVID to provide information to our providers so they can go onto a portal and pull down their patient roster and see who's eligible for recertification. So they you don't have to call, you don't have to like go through a lot of administrative hassles. You can just pull it from the website and stratify your members to say, these members need to renew once a year, these members need to renew twice a year, these members need work requirements, these members don't, these members are immigrants, so I have to check their eligibility to make sure they're still eligible to enroll. So those are sort of the 3 buckets we're going to try to do to help our providers. 70% of our members use a community provider like VIP, so it's very important to us.
Great, thanks, Errol. And Shannon, from the foundation perspective.
Sure, and I love that you call this the softball question. It's like,
I'm sorry, I put that in quotes.
Sure.
That's a humor.
So one thing just to ground our conversation a little bit too, that I think is important for everyone in this room is that Mother Caribbean Health Foundation as a philanthropic organization sits in a bit of a different seat. We are we actually are not as close to the client level as Errol and as Debbian, but we're working directly with nonprofits. So our partners are our grantee organizations, and we are doing a lot of funding of those organizations who are providing direct services. So when I speak, I want you all to know we're probably a little bit more insulated in our existence in a day-to-day and some of our work, and I think that's important as we talk. I recently saw a statistic about philanthropy, that if you combined all of the foundations together, we could not touch that $1.1 trillion that Carla so frighteningly shared at the start of our conversation. No, it's a real number, and I think it's something that needs to be grappled with. So at Cabrini, we are working to fund our grantee partners. We actually just had our Q4 board meeting today, where we approved grants that y'all will learn about shortly. But one of the things that I think is important to think about is foundations have some other tools that they can use. So we're having conversations around community voice. What does that mean to actually listen and learn from those nonprofits, but also all the infrastructure around them? Our foundation is focused on New York State. I know we're sitting right now in NYU in this beautiful building, but I grew up in Western New York and Rochester, New York. When you think about the state, it is massive. And there are a lot of different populations and settings and people experiencing quite a different reaction to H.R.1. So one of the things that we're focusing on is listening. I'm looking directly at Kim Chen, who's one of our program officers. They are doing some convening and conversations right now with our grantee partners around what are you going through? What are you anticipating? Some of the discussions that Debbian and Errol just shared. But it's important for us to start to think about how we can convene and bring some folks together to do some of that education, to understand the impact of this. And thinking about tonight and the name, Navigating H.R.1, one thing that I was thinking quite a bit is this is a great topic, a great conversation, and I love that you all came out, but it's interesting that we're navigating it. This conversation around entitlements in this country is long happening. So this moment feels like a culmination of all those things together, but it's really about centering where do these people go, and nonprofits are already working so hard. It's not an easy job. The scene is not easy to start with, and this has exacerbated something that feels really, really frightening at this moment. So I just want to, as we talk today, think a little bit around, yes, this is tough, but we've been on a trajectory towards this, have we not?
Thank you very much. I think what's also really interesting is I heard a big theme of education, educating your staff, educating the clients, the patients in a culturally appropriate way. And instead, some way, Shannon says it sounds like, you know, you're being educated by your grantees and you're listening to all the different perspectives across the state.
Right.
Shannon, just to follow up kind of from the Mother Cabrini Foundation, that your mission is you focus on healthcare workforce, behavioral health, access to health, and social determinants of health. So how does, and you had said early on, and we were preparing, you mentioned this, that you know, over the $1 trillion worth of cuts you cannot touch. However, I will say that early, when H.R.1 was first passed, anecdotally, I would hear people say like, oh, we're gonna, not that it was a panacea, but they would say like, oh, we're gonna go ask the foundations for money. I'm like, yeah, that's a really long line, and the pocketbook is already empty. So how do you approach this need for increased funding at this time?
And to answer that too, they are and they should apply to foundations and look for money. To give you a little color in the philanthropic space, Cabrini is unique in that we have an open LOI process. So for those who have been in the grant writing space, most foundations are a don't call us, we'll call you kind of energy. We open a portal every spring and we receive, I don't know the number, I'm looking at Kim, yeah, over 2,000 applicants and end up with 100+ grants by the end of that process. One thing that we are thinking about right now is how we can directly respond to the folks who we already fund. So I'll give you just a quick aside. We've been approached by government officials and organizations to add to their funds when it comes to the crisis around SNAP. And one thing our CEO shared is, with all due respect, I'd rather give that grant directly to an organization that we've already vetted, that we already know what they're doing, and we're closer to the front lines than to, make a pass through an intermediary where folks are already losing money. So that's one thing, is having those one-to-one conversations. And then Elizabeth, just another note too, as I think around unmet need. I mentioned this morning we had our Q4 board meeting. There was a great graph of our program areas, and you could see each one, and then you could see where we fund, and there was a literal gap. And one of our board members said, that is a beautiful visual representation of unmet need. Imagine it next year. And that's one of those things as we start talking with those grantee partners is to really think about, you're already applying in ways and spaces that are unmet. How can we think about that and other ways we can support you that might not necessarily be grant dollars, but perhaps we can host a convening and give you some space where you can perhaps solicit some individual donors or think through some of those education topics that Errol and Debbian mentioned.
And Shannon, just a follow-up question. What advice would you have? You talked about kind of the one-on-one relationship and getting to know the funders. What advice would you have for other organizations who are seeking funds from charities or foundations, particularly during this time?
Yeah, so something I say a lot about Cabrini is apply early, apply often. A lot of organizations think I'm going to apply for a grant. I have this one project. I'm going to write this beautiful grant. You can apply at Cabrini to any number of our program areas. So you might have something that touches healthcare workforce and access to care. Apply same grant application twice. That's a great way to do this. And also consider too thinking around who you might be able to partner with in some of those spaces. So foundations love scale, they love impact, they love, big reach. And that's another great opportunity to think around how something can be sustained beyond just the one and done grant.
Debbian, I wanted to get back to, I'm going to switch gears a little bit. You spoke earlier on about the need for redetermination, and that's going to be a strain on your workforce. How kind of operationally do you think about that when, one of the primary focuses is actually the clinical care, but now it's more emphasis on kind of this wraparound services. How are you you spoke about it earlier, but how kind of tactically are you thinking about that?
Thank you, painfully. So, because we offer so many services and a menu of services, sometimes it complicates things and sometimes it makes it easier for us. And I'm still trying to figure out if H.R.1 makes it easier for us or is more complicated because of all the services that we offer. But, I think with every challenge, there are opportunities. And so I take this as an opportunity for us to expand our services and make sure that people remain enrolled in Medicaid and other benefits that they need. So what we are doing from the ground up is we're educating the front desk staff, so I'll be very tactical. The front desk staff to address people differently, right? Because at the end of the year, a subset of our patients will be losing their benefits. And so providing that financial literacy to people at the front when they come in, targeting people who we know will be losing their health insurance and having those conversations to see if they can afford to get what they can afford to pay, because we have what's called a sliding scale, sliding fee scale, based on income. And so making sure that people can pay what they can. And if they can't, educating them that we will not deny them care, enrolling them in our medication program, which is our 40 program, so that they can get medications and they won't go without their medications. So that's at least level. Then we're looking at our organizational efficiency. How efficiently are we managing our organization? Looking at spending. Are we wasting a penny? From the toilet paper to the hand towels, just looking at every spend in the organization to make sure that we are not wasting a penny and we can redirect those funds into our uncompensated pool that we have internally. Externally, I am in so many different meetings, closed door meetings with philanthropists, with payers, with government officials, talking about ways how we can increase the indigent care pool across the state to cover people who will lose their insurance. Some discussions have been successful, like from California to Puerto Rico to Albany, all in the last week and a half. So that using the voice of advocacy, then we're partnering. We're looking at partnerships. How do we partner with our stakeholders meaningfully? Because they're partnerships and they're partnerships, right? And so how can we partner so that the trainings, for example, that we don't provide in our workforce development program, who can provide those? We're also partnering with community members to say, if you hire over patients after we train them or our trainees, we will advertise your business on our website, or we'll, come to meetings with you. So we're doing a lot of swapping of services to ensure that we can provide for them. We're also talking to our partners to say, if we set up or if you have a volunteer program, we can get some of our patients who will be losing their benefits into your volunteer program. We'll support you. We'll do everything that we can to support you while those patients are in. So those are some, there are a list of things, but I think, and of course, education and using resources from the state, from our payer partners, to develop simple materials in different languages so that we can hand out to our patients so they know what's coming. And Errol is still correct. It's not just the patients who will be losing their benefits, but the entire population that we serve, because they too have family members, they have friends, and so it's not just them, but everyone in the ecosystem in which they operate. So it's work.
Yeah. I'm also hearing a lot of creativity with all the partnerships. I'm wondering how many of those organizations did you already have a relationship with versus like, this is a need and let's kind of pound the pavement and figure out how we can work together.
Yeah, some are new and some we have relationships with, but the relationships have changed. Since the discussions about H.R.1, partnerships have changed. And so everyone's looking at the types of partners that they have and how to maximize those relationships.
Thank you. I'm gonna switch gears because initially the initial question to Debbian was about some of the redetermination process. So on the flip side, Errol, on the health plan side, one of the risks of all of that, there's going to be less there could be shorter window for retroactive payments and the redetermination. How are you, and then so there's a risk of people kind of jumping on and off Medicaid because of the paperwork. How are you approaching this to kind of avoid that churn so people can continue to get care?
Yeah, and just to speak to the churn piece, the reason why it's such an issue is because it breaks down continuity of care. And so, for example, VIP has a panel of members that have a first ID card. She's working hard to make sure they get their care. When they drop off, we have to re-enroll them. Now there's not a 90-day look back, so we have to wait. And this is happening now, the pending acts where this New York State has to pay CMS and determine if the paperwork was correct. And so that could be a gap of care of a month, 2 months, 3 months. That means the patient that has medication is not getting their medication filled. That means they're uninsured, they're ending up in an emergency room, which means they're getting care the most expensive way possible. So the prevention of the churn is to keep continuity of care so that the patient can keep getting the care they need, especially if they have chronic diseases. One piece we work on, Health First, is value-based. And what that means is, since we're a nonprofit, after basically CMS in New York State pays us for every patient we enroll, then we pay claims to providers that are under care, and then there's money left over. A typical for-profit insurance company, that money that's left over goes to shareholders. Because we're nonprofit, the money left over we return back to the delivery system. So it goes to hospitals, it goes to providers. And so that's another way of, if we can render the care well, have continuity of care where they're getting the care that they need, prevent an emergency room visit, prevent insulin shock because they're taking their meds every day. We actually have savings, and we return that savings back to the delivery system. So it's this virtuous cycle, so that the providers can use that money to assist. So that's one piece. The other piece is looking at the family together. So unfortunately, the way government programs work, they look at individuals. So an example is if a mother who's in Medicaid becomes, earns a little bit more money and starts making, say, $30,000, $35,000 a year, they would get kicked off of Medicaid and have to join another product, which we call the essential plan. Now, if that same mom gets pregnant, guess what? They're eligible to return back to Medicaid. That's very confusing. But why would you come back to Medicaid? Because you get WIC. And WIC now can help you get food, diapers, and other things so that you can take care of your baby. There's a lot of, you can have a PhD and still find it complicated to try to figure out that process. And so what we do is try to alleviate that stress, and that's where the churn comes down. One big change happening, and New York, we're in a better position than most states, because what New York is doing is they figured out of the $1.5 trillion cut over 10 years, it's a $10 billion hit to the state, and they're looking at ways to fill in the gaps. And so one of the ways they're filling in the gap is they just submitted to CMS a new plan to try to keep as many people as covered as possible in that essential plan I was talking about. One of the outcomes of that is there's a essential plan 5. This is one of the plan designs in there that's going to go away. So these members are now going to have to find new coverage, and helping them find that coverage when they drop off is important. I talked about the family when we did renewals. If you have to renew a child, you might as well think about the entire family at that one time, rather than calling the mother 3 months later to say you have to renew too. If you're in that household and there's a senior, you might as well see if that senior is eligible for Medicare at the same time. And so these are things that the government programs don't look at families, they look at individuals. So they say, you're eligible for this, you're eligible for that, you're eligible for that. But what we try to do is take a step back and say, let's take care of the whole household at one time. Things that we ask in the home and when we're having these conversations is, are you food insecure? Do you have housing insecurities? Because of the 1115 waiver that's out now and is happening, we can refer them for resources in the community. And it's kind of this, we're all connected because Mother Cabrini making donations to these same organizations. Like for example, I sit on the board with H.R.1 Foundation. They do screening. And they're in barbershops and they're in beauty salons, educating members about all these changes that make it really relevant for them. So they're getting funding from a grant to then talk about these services so that they can roll with Health First and then end up at VIP. So it's like all the dots are connected. But it's like you said, it's work, it's a lot of coordination. And what we have to say at Health First, that's make every moment count. And so if I'm on the phone with them and I have their attention, I have to get as much information as possible. So let me talk about Medicaid, we talk about Medicare, so we talk about SNAP, and we talk about VIPs, services that they offer. That we make sure you have a PCP, try to get it all done, so that I don't want to call a member 18 times. I try to consolidate it into one meaningful call, and that's what we try to do.
It really strikes me how much you have had to train your workforce, because I imagine, like, as a family doctor, I am a generalist, so I love doing lots of different things. You're a family nurse practitioner as well, right? So we do big, but I imagine these people historically might have had this little piece of the pie, but now it's like trying to cover as much as possible. That's pretty impressive. Lots of education and training for that. Shannon, I wanted to ask you a question. You had, we touched on it earlier, but I want to get back to the, how do you balance the kind of that large scale transformative funding that Mother Cabrini is known for versus like the need to be nimble and flexible when there's a crisis? For example, food insecurity with SNAP benefits were not coming through. How do you balance that as a foundation?
Yeah, it's a great question. And I think I shared earlier, we're 7 years old, so we're a baby in this game. But when you look at our peer funders, you do see that tension, and we have that tension quite a bit at Cabrini. As a foundation, we are very proud of that responsive grant making. It allows us to be nimble, and it allows us to have some real, clear, direct response to what requests are coming in. But there's a lot of theory in the philanthropic space around what our foundation's here for. Are we here to put a Band-Aid on the wound that's in front of us? Are we here to think about large-scale systemic transformation? And I was just also in Somos in Puerto Rico working with some of our grantee partners at an event and had a discussion with an organization called Rethink Food. And that's a great food funder, our organization that we fund. Rethink does something a little bit different than a traditional food bank. Matt Joswiak, who's their founder, Matt was a chef, trained as a chef, working in, really, really fancy restaurants, Noma and 11 Madison Park. But what Matt saw and learned is that there's so much food waste. So he thought, could I create an organization that focuses on excess food and a need for food? And one of the things that he did, and you're meeting folks with Cabrini, is during the pandemic, he was able to scale and to turn 11 Madison Park, when it was out of service, into a commissary kitchen and start serving meals that were culturally appropriate, nutritious, restaurant quality meals to seniors with another of our grantee partners, City Meals on Wheels. So that kind of thinking around how organizations can come together, how they can do similar work and grow in the same direction is helping us move a bit more towards the systemic change. but we always want to have some ability to be responsive. I was a fundraiser for many years prior to being on the philanthropic side, the literal other side of the coin. And it's very hard to find a funder to take a meeting with you because most foundations have their priorities set. It's not a bad thing, but it's when you're thinking around, I'm in a crisis, I need to raise this money. A theme, Elizabeth, that I keep hearing throughout this is it's work. You know, everyone who's doing this work is already probably underpaid and stressed and doing quite a bit. And then that funding piece is existential. You don't get your fundraising dollars, you know, a CFO somewhere is yelling at you and you're trying to figure out how you make ends meet. So in thinking through that, one of the things we try to do is make sure that we still are accessible. We have a great community engagement team that's happy to meet with and learn about any organization. Doesn't mean that every organization is going to get funding, but we think that relationship is important. Very much ties to, and I don't know how much folks know about Mother Cabrini herself, but Mother Cabrini arrived in New York at the turn of the 20th century, tiny little Italian nun, a woman in spaces where people didn't want necessarily women, much less nuns, and really transformed and built out a system of care. She's considered the forebearer of Catholic Charities, built orphanages, schools, and literally was on the front line saying, how can I be of service? So we both want to honor that legacy, but also be thoughtful around how we can think bigger, longer term solutions.
Thank you, Shannon. And then just a follow-up question to that. There may be some I know there are several students in the audience here and other people in their career who may be interested in a career in foundations or charity work. Do you have a suggestion for like, as they are, you know, that tension that we're talking about, that we're just talking about, the long-term versus kind of the urgent need, what is it like a framework or practical skills you would suggest to them as they're thinking about that?
I would suggest that people get really excited about the topic you're interested in. So I'm sitting here in my Mother Cabrini hat, but I also serve on the board of Philanthropy New York, which is a philanthropic sector organization. And I think about the sector and so many foundations that do a lot of different things. If you are passionate about art and want to be at the Andy Warhol Foundation, become the best and smartest and you know, art student that can be. I also think for foundations, really thinking through theories of change is something that you'll hear quite a bit. I'm smiling at it, seeing one of our Cabrini vets here from Olivia. But in thinking through problems, we added an evaluation and learning team about, I don't even know what year it is, 3-4 years ago, to help us not just respond in real time, but also to think about what are we trying to solve? Let's dig deeper into a problem, understand what the issue is, and what piece of this the foundation can maybe carve out and take a stab at solving. A little quick example, which isn't quick at all, but a couple years back, a member of our board suggested we should solve the nursing crisis. And we all walked out and said, okay, we have to solve the nursing crisis overnight. But what that team was able to do along with our program team and our community engagement team is really think through what are some issues in that problem that this foundation could think about. We ended up launching a $51 million initiative of 13 safety net hospitals throughout New York State, focused on providing an accreditation to some nurses in those hospitals that are magnet status or pathway to excellence. And the studies showed us that when nurses have these accreditations, that they do better. There's less burnout, there's more excitement about work, retention goes up, and the best thing is the outcomes for patients are better. And that's what we're really here to do. So that just launched. I keep picking up where Kim in the audience. Kim's part of that team, as is on our community engagement specialist here. But that's one of the things that we want to watch in a long-term arc to see how the foundation really does in this space, has a learning collaborative with the hospitals, how they can learn from each other, and then think about scale. So I don't know if that answers that fully, but I don't know if the students in the room need any more tactical advice.
Well, we're going to turn it, and probably one more question, and then going to turn it over to the audience to ask their questions. I like how you're talking about follow your passion, like what you care about, and then the when you said solve the nursing crisis, I think I started getting palpitations. So breaking it down and really kind of doing a root cause of like, what are those factors and what can you actually influence? So
And I think those palpitations are good, by the way. I think people should dream big and think blue sky solutions, but yes, it is daunting, to say the least.
So my final question for the panel before I turn it over to all of you is, you know, these are certainly unprecedented times. We didn't even talk about the government shutdown and, you know, many other things going on in society right now. As leaders of your organization, and there are, you know, there are student leaders, there are mid-managers, there are other people at various levels in this organization. Leading through these type of times, what advice do you have for folks? What are those kind of those pearls?
Sure.
Yeah.
So I think one thing to latch on to is pressure is a privilege, and I've shared that with my team many times. So I'm just take a step back, like what's happening now, we focused on Medicaid, but in actuality, this is gonna have reverberations across the entire healthcare ecosystem. As hospitals see less Medicaid patients come to their offices, they're gonna ask for big rate increases from the for-profit insurers, which you're seeing now, probably a bunch of terminations that are in the news. And so this is a time where face the pressure and say, it's a privilege to be in this position. So we have 6,000 employees at Health First. We go to bed at night, one saying, I hope I advance the ball on equity a little bit further than it was the day before. And then wake up in the morning really passionately ready to tackle the hurdles because we think about the person that's on the receiving end. So when we can process a claim right the first time, when we can pick up the phone, answer the question for the first time, it's a privilege to be under this pressure. So we are facing a tidal wave, financial hits, calamity, confusion, and if you really just center yourself around but if we actually do what we're supposed to do, a customer, a patient on the other side will be better for it, and we're so thankful. And so we do it to be a voice for the voiceless, and really say it's our mission. I'm just recalling like the last time, so I graduated in 2013, when I was here for school, the ACA had just passed. And I was eager beaver, I was like, I'm gonna read this whole bill. All 2,000 pages. And H.R.1 is coming out, and if there's students here, read the whole bill and be passionate about the unintended consequences of policy, be passionate about what you can do in your own world to make change, because you don't have to be in a C-suite, and be passionate about, at the end of the day, someone on the other end is going to be better off for it. And if you're grounded in that, I think you'll be great. And your team will feel passionate about it and follow you as well.
Thank you.
Debbian, what advice do you have?
So, you're so right. I'm so what I was about to say. I'll add, don't panic. There is noise, and you're going to hear noise, and some noise is good, because some noise motivates us and really gets us moving, like, you know, we're gonna fight the good fight. But don't listen to all the noise, because then you get distracted. Stay the course, understand what your goals are and why you're in your purpose. It's so important for us to know what our purpose is. And that will drive you, and don't be afraid. Don't be afraid to defend what you believe. It's right. Or if you believe strongly that what you're doing, the work you're doing is the right thing to better the society for the next generation or the next person to come. If it's something you're doing in class, think about the next student who's going to sit in that chair after you and go after it, give it everything that you have. It's also very important for you to find good mentors, because none of us can do this alone. Let me tell you, I have been so busy, you know, day after day after day with everything trying to plan to make sure that my organization stays sustainable for all the people that we serve. And I was so happy, I was about to call my colleague at HLA. It's on my to-do list, and you know the to-do list that you keep turning the pages, right? Yeah, I'll get to it, yeah. And yesterday he sent me an email and he said, I can help you with such and such and such. And he knows it's something that we have to do, we must do, right? And I was like, oh, thank God. You know, I didn't have to initiate that. All I had to do was respond. So great mentors and great people who are aligned with you is what you'll need to get you to the next phase in your career. It doesn't matter what your career is. People talk about network. It is so, so important, especially now.
Thank you, Debbian, it's lovely. And I'm gonna give that feedback to my colleague. Shannon.
I would encourage folks to lean into your why. Philanthropy as a word means love of mankind. Sounds very easy, very simple. I'm gonna update it for 2025, the love of humankind. But the concept here of seeing people, loving people, taking care of each other, being part of community is a big part of our why. So lean into your why in these times of crisis. Errol hit on something that I also very much love, which is lead from the seat you're in. I'm a big believer in brave spaces and just saying the thing. That becomes a little easier when a lot of people are saying the thing at different levels, and it builds culture where we can all be truthful and honest with each other. So lead from the seat you're in and do it with a little bit of courage and bravery.
I love, these are great pearls of wisdom. All right, we have our first question from the audience, please.
Yes, I'm Michael Myers, president of the New York Civil Rights College. It sounds very dire, but there are people who are exempt, protected from all these cutbacks. For example, I know a lot of people who have Medicaid and who are also Medicare, senior citizens. Are they exempt from all these cutbacks and therefore protected? And secondly, what about admissions to hospitals? Has that been changed too? Because I thought there was a law that protected people who wanted to come to the hospital and not be sent away because they're a private hospital. Has that law changed too? I just wanted to.
It's a great question. So there are exempt folks, and this is where the education is important for the community. So duals are people who are enrolled and eligible for Medicaid. They make less than $15,000 a year, and they're over 65. So they're eligible for two products, Medicaid and Medicare. They are exempt from the 6-month recert. They still have to recertify once a year their Medicaid portion, but they don't have to do the 6-month recert. So for the most part, knock on wood, as of today, Medicare has very small changes. It's subtle. The work requirements and the 6-month research for Medicaid is, again, childless adults. If a person has a child under 14, they're exempt. If they are on SSI, they're exempt. If they're in school, they're exempt. So there's a whole laundry list of exemptions for people, which is going to be confusing. On the work requirement side, and you brought this up about volunteering, if you're working 80 hours a month, you can be exempt from needing to prove that you're working. And so those are childless adults that can at least get some volunteer hours can stay enrolled in Medicaid. And it's still determined on how to establish how they're working, but that's another exemption as well. As for the hospitals, yes, by law, an emergency room cannot turn you away. By law, and so that continues. The issue really is if you don't have primary care, if VIP gives primary care, like I'm your PCP, you don't want to go to the emergency room for a tummy ache or a headache. Like those are things that should be driven to to a PCP. So our concern is as people fall off the rolls, they end up in the emergency room. 9 times out of 10, potentially get admitted, and now we have this burden of cost because emergency room is the most expensive place to go, where it should have been treated elsewhere. So that's the biggest concern.
I'll also add two things, and you're absolutely correct, Errol. Aside from cost, a family nurse practitioner, I'm always thinking of people and then cost, because I believe if the people follow the cost leader, it will come your way. Money will come if you do the right thing. If we have more people using emergency rooms, what that's going to do, and we're in a crisis with workforce. We're still in a crisis. There's not enough nurses, not enough doctors, not enough anybody anywhere. And so what that's going to do is people who need critical care in emergency departments, we're slowing that care. And so people will die, let's face it, right? If our emergency rooms don't function appropriately, there's no human power that's going to speed things up, or if we don't have enough staff going through when there's more demand coming in. So we have to think about that too, in addition to the cost. And the other two exemptions that we're not clear how it's going to work yet are people with substance use disorder and people with mental illness. And it's not yet defined what we're going to do with that. Right now, there's a lot of advocacy. Like, I have been advocating fiercely. I sit on the National Board for Mental Health, Mental Wellness. And so we have been advocating fiercely at the federal level and also the state level to ensure that people who need these waivers will get the waivers, and we have to recertify at the same pace as the childless adults.
Thank you. I think there's a question over there. Yes, please.
Hello, everyone. Hi, my name is Stephanie Tahiti. First, I want to say thank you for creating space for political intelligence. I'm really grateful to be here. I work for the Health and Welfare Council of Long Island. I'm sorry, hi. I oversee the healthcare programs at the agency. I'm very familiar with Health First and Mother Caprini. Not much familiarity.
Up to the Bronx.
Yeah. Yeah. So my question really is about collaboration. I know you all mentioned education. Really the reason why I'm mentioning collaboration is because I wanted to know if currently there are any outreach initiatives being planned for 2026. The reason why I'm saying that is because I work for a nonprofit and I would love to work with you, Errol. You know, like, how can we actually better provide that education piece to the, the population who really needs it? When I think about accessible language, I want to make sure that you're talking about seniors, you're talking about anybody, because people are very confused right now. I can tell you because my team worked directly with the clients and people are very confused. So I just wanted to hear a little bit more about that. Also want to say I'm a prospective student, knock on wall or wood, for NYU Wagner, so I'm really happy to be here. Thank you.
Well, I'll start too. One of the things I might have undersold a little bit is some of the convenings and events we do. So would love to, we can connect after and talk a bit more, and maybe there's something to do together in that space and combine powers. But I think one of the things that is sometimes tough is there's a big surge of information, and it may not always be the right information, or people are going to different things, and you're spending a lot of time re-educating folks on what is correct and what's not. So would love to plan something with some of these wonderful experts with you. That's a very easy thing to do.
Thank you.
We work very closely with your
The next
organization.
time, yes.
Vanessa. So, I mean, if we have to figure out how to have a meeting, we can. But you bring up a good point. And I learned this the hard way with the ACA. When we first did education in the community, we would say 138% of FPL.
Yeah.
No one knows what that means.
Nobody knows.
So you have to learn how to make it digestible for
Yeah.
folks,
Yeah.
so they understand what's happening. I learned that.
And I will just add here that trade associations are great to collaborate with, because whatever field you're in or whatever entity anyone's in, there are trade associations for every discipline. If you're OPWPD or OMH or OASIS or whatever, there is a trade association that you should be collaborating with, because those can put you in contact with folks. And a lot of those trade associations now are developing patient materials that you can use, so people don't have to reinvent the wheels, but you can contribute in developing those materials right now.
Great, I think there's a question in the back, please.
Thank you. I'd like to ask a bigger picture question, if I could, in terms of, could you comment on the criticism coming from both the left, Bernie Sanders, and the current president about the gatekeeper function of health insurance companies and the huge amount of money that goes to insurance companies instead of to healthcare? Thank you.
I can start. Yeah, I think it's a good conversation. So, what I believe you're referring to is one of the big debates during the government shutdown was why give these subsidies, enhanced subsidies that we still don't have a decision on, to the insurance company to lower the cost for a patient. Why not give it straight to the patient and let the patient have autonomy to figure out what they'd like to do with the money and put it straight in their pocket with an HSA account. I think that's an amazing innovation if they want to pursue that. My personal opinion, I say this working for a nonprofit health plan, is that there were provisions in the ACA that capped the profits that for-profit companies could make. So today, the ACA is still enacted, a health plan cannot make more than 15% margin on the products they sell in the individual space and in the small business space. But 15% of a big number is still a big number. So the for-profit plans have billions and billions and billions of dollars. You can Google how much money that they have. So much so that when the bill came out and it was signed, H.R.1, you saw the for-profit stocks plummet, and they're still plummeted because they realize that a lot of these plans are gonna lose folks that are not insured. I think there should be a conversation on the profit that health plans take, because any profit that a health plan takes is not going to care. And I can say that because for Health First being a nonprofit, and also Metro Plus is in the room. Two nonprofits in New York State that any money left over is returned. We don't retain the payments or the profit. It's three nonprofits, yeah. They don't retain the margin inside their four walls. It goes back out. And the beauty of a nonprofit is they have to disclose their 990. So you can go onto the website and see their 990 and see how much revenue they earned and how much was left over and what happened to it. So I agree, there should be a debate around how much money is extracted from the health economy around insurance companies, and that people should speak about it. My personal preference, working at a nonprofit, I think nonprofits are the way to go, and that's a debate that should happen. Have to have other people weigh in.
Thank you for reminding us that we have a capitalist healthcare system.
Yeah.
So, was there another question? Yes, please.
I might need a mic. So good evening, thank you for this panel. I'm Adriana Body, I'm from the Staten Island Partnership for Community Wellness. I'm a 2003 alum. I have a question, it's a little bit tangential but related. It's about the 1115 waiver. And for those who are not familiar, right now there's a Medicaid waiver, and a lot of nonprofits are being reimbursed by plans to provide these health-related social needs. We're doing massive screening, massive connecting people to services. What is the forecast? Like, what are people? I know there's advocacy going on, but like we're building systems only to.
Yeah. I'm sorry. So the 1115 waiver, just so folks know, is a demonstration that New York State's filed with CMS to say, let's take $7 billion, it's $7.5 billion to try to reimagine healthcare. And part of that reimagination was one of the reasons why people are sick is because they don't have food, they have housing insecurities and all these other things. And so they came up with this process to screen members to see what social needs they may have. And this is the second time we've done this type of demonstration. And this time they gave the money to the community-based organizations versus the hospitals. Last time they gave it to the hospitals and it kind of got stuck. But this time we wanted to actually getting to the nonprofits. Right now, the demonstration is supposed to end Q1 of 2027, March 2027. Ironically, it got approved under a previous administration. There is a strong likelihood the current administration wouldn't extend it. So we're building the infrastructure, but what the hope is that the reason why we're doing these screenings is so that we can come up with like a social needs risk score. And so when you look at the data, what you find is, yes, someone is expensive, like someone who potentially has cancer, they're expensive. But if they have a house and they can get food, they're less expensive than someone who has cancer and also has food security and housing. So if we can cure those things, we can actually find long-term savings. And so we need enough screenings to prove that out. In the plan was 25% screenings. We're not there, and the numbers are not as high as we want them to be. So I think the impetus for us to screen as many people as possible so that we have the data, so that we have a best guess argument to try to fight for an extension is what we have to do. If you ask me as a betting man, I think if there's a different outcome in 2028, you may resurrect it, but I find it really low margin chance that the current administration would continue the program. So we build the infrastructure with the hope that we can use it thereafter, but that's still TBD.
Yeah, I would just add, I agree. I try to stay optimistic that this infrastructure will recycle. You know, things tend to recycle, so if we build it and it's built well enough, it is going to serve us down the road. And if we can use this now to save some money, to get us through, right, turbulent times. And, you know, I strongly believe that in the next couple of years, we're going to learn enough to pivot in a different direction. And I'm not talking about politics here, but our healthcare system. Whether it is to provide care differently, that this H.R.1 works so well, or screenings work so well, and the demonstration is so positive that it's going to lead to something. But I do believe, and I have to stay hopeful, and believe that our healthcare system it's changing right now in front of our faces, and so we don't know where it will land. And so let's go at it with all that we have to prove this demonstration and see what happens afterwards.
Thank you. Last question.
Errol talked about education and, Channon talked about how big New York is and the different populations and the way this bill has been received by different populations. I'm wondering from the political side, what place are you all and your organizations looking to proactively figure out how to do something about this bill or the next bill that's coming, because they're coming with another one in 2 to 4 years? The architects of this bill were largely championed by a large portion of people who are being legislated out of care. And in many cases, they don't understand that they're voting for people who are going to take away those abilities. And so because you're on the front lines, do you have any activities or plans, or how are you using that as a way to explain, hey, this is, kind of what you asked for, there are other options in the future, because that's part of it is, just like with the ACA, most of the people didn't realize Obamacare was ACA and they voted against one but not the other, which is the same thing.
I'll start, something that sounds very simple but isn't, which is that we want to be super issues focused. And it ties into what Debbian just said, that when we think about 1115 and giving it all we have on the topics. I love that you started with politics. I always say people pause when we say the word politics as though it's the dirtiest word. People make jokes about lawyers and politicians. Politics is another word for power. And that's what we're talking about there. If you want to talk about partisanship, that's a different discussion. But I think it's important to get really clear on what issues are important and how we can coalesce around those spaces. And it does not matter who's in office. Someone once used a term that I thought was hilarious, and I'll share with you all, which is the he-be-we-be problem. He be gone, we be here, and yet the issue persists, right? So again, I keep going back to advocacy, learning, education. On a literal political space, foundations are not allowed to lobby, but we can engage in advocacy on issues that we care passionately about, which is typically learning, educating elected officials, educating the community. And so I completely agree that we've got to get really clear, and I keep talking about the cacophony of noise that we all live in. We live in these very fast news cycles. We're swiping, we're TikToking. We got to get a little deeper. We got to get a little long form, frontline. Let's go back into kind of a deeper understanding of what we're talking about. And I think we can be of assistance in doing that.
Yeah, I completely agree with you. And he can lobby, because we'll get in trouble. But we do make good trouble. And that is advocacy. And using our voice and making sure that we partner with the longitudes and with payers and with community members and clergy, etc. To educate for elected officials, regardless of which side of the aisle they sit on, and will continue to do so, and to educate the people that we take care of in grassroots advocacy. We have what's called Advocacy Day for Federal Qualified Health Center, where we take our patients and our staff up to Albany, and they meet with elected officials and explain to elected officials, tell their stories, because, that's their story, and use their voices to advocate for what we do and how we do it. And it doesn't matter who they meet with, whether it's, what is it, blue, red, purple, orange, who cares? The stories are the stories, and human suffering is human suffering, human needs are human needs. And so if we tell our stories the right way, then we can break through. And that's the reason why I'm always in Washington, D.C. or someplace meeting with somebody. The reddest state I go to and ask for meetings with folks, so that we can have conversations.
Same here. We do a ton of advocacy as well. Our focus is on education and modeling. And so we, after H.R.1 passed, through us and also our trade association, went to districts to say, this is the implication to your district. Here's how many people are going to follow the rules. When they follow the rules, they're going to go to this hospital in your district. That hospital is going to be strapped for cash. And then they're going to call you and say, I need funding. So we explain that to them very deliberately so they see what's happening.
Do you think that message is getting to the individual voters so that they understand the ramifications of their vote?
Yeah, I think these are one-on-one conversations. So it's hard. It's hard. I'll give you an example. Right now, there's messaging that says all of the cuts are really just fraud, waste, and abuse. So they're like, we're just doing fraud, waste, and abuse. Who doesn't want to cut fraud, waste, and abuse? And so to do the education of there's always fraud, but you're talking about 1%, 2%. We're not trying to squash 70% of fraud. You're like, well, what do you mean? You have a bunch of undocumented people on the rolls. It's like negative. You actually don't. These are in Medicaid in New York State, outside of immigrants over 65 and outside of children that are undocumented. It's a very small number, and if it does happen, it's emergency Medicaid, so you're only doing an acute need, and that's it. And I'm like, huh? That's not what I was told, and so we have to say, I don't know what you're reading, but these are the facts. These are the facts, and the amount of paperwork a member has to bring to get eligibility, pay stubs, updated passport, visa, and we're checking the eligibility, we're checking the data, and doing it again every year. It's like, we do that every year and 20% fall off the rolls already. You're gonna do it twice a year, what do you think's gonna happen? So those are the times you can educate them on this is what's actually happening, and this is your district. Yeah, and so, you know, you're gonna lose out. So we do that as much as we can.
I'll just tell you a quick story to that. I was talking to some of those during the SNAP when people weren't receiving their SNAP benefits because, you know, we have a lot of rural patients obtaining benefits. And I asked the individual who said, oh, it's good, you need to not give them subsidies, whatever. You know the language I'm talking about. And I said, do you have a mortgage? And the person said, yes, I do. I said, so you do get subsidies yourself, don't you? And the person couldn't answer that, right? I said, I get subsidies, I have a mortgage, right? So it's how we educate people and have them understand and tell our stories.
Great point. Thank you, I want to say, for our fabulous panelists. Thank you for a very engaged audience. Please keep your questions coming over food and drink in the back.
Thanks, Elizabeth.